Welcome to the Dr. Izzy's Medical Podcast channel.
Chronic lymphocytic leukemia. Chronic lymphocytic leukemia, CLL, is a type of cancer in which the bone marrow makes too many lymphocytes. Early on there are typically no symptoms. Later non-painful lymph node swelling, feeling tired, fever, night sweats, or weight loss for no clear reason may occur. Enlargement of the spleen and low red blood cells may also occur. It typically worsens gradually over years. Risk factors include having a family history of the disease. Exposure to Agent Orange and certain insecticides might also be a risk. CLL results in the buildup of B-cell lymphocytes in the bone marrow, lymph nodes, and blood. These cells do not function well and crowd out healthy blood cells. CLL is divided into two main types, those with a mutated IGHV gene and those without. Diagnosis is typically based on blood tests finding high numbers of mature lymphocytes and smudge cells. Early-stage CLL in asymptomatic cases responds better to careful observation, as there is no evidence that early intervention treatment can alter the course of the disease. Immune defects occur early in the course of CLL and these increase the risk of developing serious infection, which should be treated appropriately with antibiotics. In those with significant symptoms, chemotherapy or immunotherapy may be used. Signs and symptoms. Most people are diagnosed as having CLL based on the result of a routine blood test that shows a high white blood cell count, specifically a large increase in the number of circulating lymphocytes. These people generally have no symptoms. Less commonly, CLL may present with enlarged lymph nodes. This is referred to as small lymphocytic lymphoma. Less commonly, the disease comes to light only after the cancerous cells overwhelm the bone marrow, resulting in low red blood cells, neutrophils, or platelets. Or there is fever, night sweats, weight loss, and the person feels tired. CLL can be grouped with small lymphocytic lymphoma, SLL, as one disease with two clinical presentations. Wherein, with CLL, disease cells propagate from within the bone marrow, in SLL they propagate from within the lymphatic tissue. CLLs are, in virtually all cases, preceded by a particular subtype of monoclonal B-cell lymphocytosis, which is MBL. This subtype, termed chronic lymphocytic leukemia type MBL, is an asymptomatic, indolent, and chronic disorder in which individuals exhibit a mild increase in the number of circulating B-cell lymphocytes. These B cells are abnormal, they are monoclonal, produced by a single ancestral B cell, and have some of the same cell marker proteins, chromosome abnormalities, and gene mutations found in CLL. Complications. Complications include a low level of antibodies in the bloodstream, hypogammaglobulinemia, leading to recurrent infection, warm autoimmune hemolytic anemia in 10 to 15% of patients, and bone marrow failure. Chronic lymphocytic leukemia may also transform into Richter syndrome, the development of fast-growing diffuse large B-cell lymphoma, prolymphocytic leukemia, Hodgkin's lymphoma, or acute leukemia in some patients. Its incidence is estimated to be around 5% in patients with CLL. Gastrointestinal involvement can rarely occur with chronic lymphocytic leukemia. Some of the reported manifestations include intussusception, small intestinal bacterial contamination, colitis, and others. Usually, gastrointestinal complications with CLL occur after Richter transformation. 2 cases to date have been reported of gastrointestinal involvement in chronic lymphocytic leukemia without Richter's transformation. Diagnosis. CLL is usually first suspected by a diagnosis of lymphocytosis, an increase in a type of white blood cell, on a complete blood count test. This frequently is an incidental finding on a routine physician visit. Most often the lymphocyte count is greater than 5,000 cells per microliter of blood but can be much higher. The presence of lymphocytosis in an elderly individual should raise strong suspicion for CLL, and a confirmatory diagnostic test, in particular flow cytometry, should be performed unless clinically unnecessary. A peripheral blood smear showing an abundance of damaged cells known as smudge cells or smear cells can also indicate the presence of the disease. The diagnosis of CLL is based on the demonstration of an abnormal population of B lymphocytes in the blood, bone marrow, or tissues that display an unusual but characteristic pattern of molecules on the cell surface. This atypical molecular pattern includes the co-expression of cell surface markers clusters of differentiation CD5 and 23. In addition, all the CLL cells within one individual are clonal, that is, genetically identical. In practice, this is inferred by the detection of only one of the mutually exclusive antibody light chains, kappa or lambda, on the entire population of the abnormal B cells. Normal B lymphocytes consist of a stew of different antibody-producing cells, resulting in a mixture of both kappa and lambda-expressing cells. The lack of the normal distribution of these B cells is one basis for demonstrating clonality, the key element for establishing a diagnosis of any B cell malignancy. The combination of the microscopic examination of the peripheral blood and analysis of the lymphocytes by flow cytometry to confirm clonality and marker molecule expression is needed to establish the diagnosis of CLL. Both are easily accomplished on a small amount of blood. A flow cytometer instrument can examine the expression of molecules on individual cells and fluids. This requires the use of specific antibodies to marker molecules with fluorescent tags recognized by the instrument. In CLL, the lymphocytes are genetically clonal, of the B cell lineage, and characteristically express the marker molecules CD5 and CD23. These B cells resemble normal lymphocytes under the microscope, although slightly smaller, and are fragile when smeared onto a glass slide, giving rise to many broken cells, which are called smudge or smear cells. Hematutz's CLL score allows the identification of a homogeneous subgroup of classical CLL, that differs from atypical mixed CLL for the 5 markers expression. Matutz's CLL scoring system is very helpful for the differential diagnosis between classical CLL and the other B-cell chronic lymphoproliferative disorders, but not for the immunological distinction between mixed atypical CLL and mantle cell lymphoma. Discrimination between CLL and MCL can be improved by adding non-routine markers such as CD54 and CD200 among routine markers. The most discriminating feature is the CD20-CD23 mean fluorescence intensity ratio. In contrast, FMC7 expression can surprisingly be misleading for borderline cases. Differential diagnosis. Hematologic disorders that may resemble CLL in their clinical presentation, behavior, and microscopic appearance include mantle cell lymphoma, marginal zone lymphoma, B-cell prolymphocytic leukemia, and lymphoplasmacytic lymphoma. B-cell prolymphocytic leukemia, a related, but more aggressive disorder, has cells with similar phenotype, but are significantly larger than normal lymphocytes and have a prominent nucleolus. The distinction is important as the prognosis and therapy differ from CLL. Hairy cell leukemia is also a neoplasm of B lymphocytes, but the neoplastic cells have a distinct morphology under the microscope and unique marker molecule expression. All the B-cell malignancies of the blood and bone marrow can be differentiated from one another by the combination of cellular microscopic morphology, marker molecule expression, and specific tumor-associated gene defects. This is best accomplished by evaluation of the patient's blood, bone marrow, and occasionally lymph node cells by a pathologist with specific training in blood disorders. A flow cytometer is necessary for cell marker analysis, and the detection of genetic problems in the cells may require visualizing the DNA changes with fluorescent probes by fluorescence in situ hybridization, molecular cytogenetic technique. Treatment. CLL treatment focuses on controlling the disease and its symptoms rather than on an outright cure. In those without or only minimal symptoms, watchful waiting is generally appropriate. CLL is treated by chemotherapy, radiation therapy, biological therapy, or bone marrow transplantation. Symptoms are sometimes treated surgically. Initial CLL treatments vary depending on the exact diagnosis and the progression of the disease, and even with the preference and experience of the healthcare practitioner. Any of dozens of agents may be used for CLL therapy. Decision to treat. While it is generally considered incurable, CLL progresses slowly in most cases. Many people with CLL lead normal and active lives for many years, in some cases for decades. Because of its slow onset, early-stage CLL is, in general, not treated since it is believed that early CLL intervention does not improve survival time or quality of life. Instead, the condition is monitored over time to detect any change in the disease pattern. The decision to start CLL treatment is taken when the person's symptoms or blood counts indicate that the disease has progressed to a point where it may affect quality of life. Clinical staging systems such as the RI 4-stage system and the Binet classification can help to determine when and how to treat the patient. Determining when to start treatment and by what means is often difficult. No survival advantage is seen in treating the disease very early. The National Cancer Institute Working Group has issued guidelines for treatment, with specific markers that should be met before it is initiated. Chemotherapy. Combination chemotherapy regimens are effective in both newly diagnosed and relapsed CLL. Combinations of fludarabine with alkylating agents produce higher response rates and longer progression-free survival than single agents. They are fludarabine with cyclophosphamide, fludarabine with rituximab, fludarabine, cyclophosphamide, and rituximab, and CHOP treatment, which is combination of those medications, cyclophosphamide, doxorubicin, vincristine, and prednisolone. Although the purine analog fludarabine was shown to give superior response rates to chlorambucil as primary therapy, no evidence shows early use of fludarabine improves overall survival, and some clinicians prefer to reserve fludarabine for relapse disease. Chemoimmunotherapy with FCR has shown to improve response rates, progression-free survival, and overall survival in a large randomized trial in CLL patients selected for good physical fitness. This has been the first clinical trial demonstrating that the choice of a first-line therapy can improve the overall survival of patients with CLL. Alkylating agents approved for CLL include bendamustine and cyclophosphamide. Targeted therapy. Targeted therapy attacks cancer cells at a specific target, with the aim of not harming normal cells. Targeted drugs used in CLL include venetoclax, ibrutinib, idelalisib and duvelisib, as well as monoclonal antibodies against CD20, rituximab, ofatumumab and obinutuzumab, and CD52, alemtuzumab. Stem cell transplantation. Autologous stem cell transplantation, using the recipient's own cells, is not curative. Younger individuals, if at high risk for dying from CLL, may consider allogeneic hematopoietic stem cell transplantation. Myeloablative forms of allogeneic stem cell transplantation, a high-risk treatment using blood cells from a healthy donor, may be curative, but treatment-related toxicity is significant. An intermediate level, called reduced-intensity conditioning allogeneic stem cell transplantation, may be better tolerated by older or frail patients. Refractory CLL. Refractory CLL is a disease that no longer responds favorably to treatment. In this case, more aggressive therapies, including lenalidomide, flavopiridol, and bone marrow transplantation, are considered. The monoclonal antibody alemtuzumab may be used in patients with refractory, bone marrow-based disease. During pregnancy, leukemia is rarely associated with pregnancy, affecting only about 1 in 10,000 pregnant women. Treatment for chronic lymphocytic leukemias can often be postponed until after the end of the pregnancy. If treatment is necessary, then giving chemotherapy during the second or third trimesters is less likely to result in pregnancy loss or birth defects than treatment during the first trimester.
Thank you for listening Dr. Izzy's medical podcast series. If you want to support this project, please subscribe the channel and like this video. Thank you.